Welcome to the deep dive. Today, we're taking a stack of extremely rigorous sources and pulling out the the actionable takeaways for clinical practice.
And our focus today is a big one. It's about triaging patients with symptoms of suspected colorectal cancer, or CRC.
Right. And for years, this has been a massive challenge. Clinicians are relying on patient histories, vague bowel changes, maybe some unexplained weight loss, bleeding.
And those symptoms alone are just, well, they're notoriously unreliable.
They generate so much anxiety for patients, and crucially, they can flood diagnostic services with low-risk referrals.
And that inefficiency creates bottlenecks, doesn't it? And that's exactly what this monumental new guideline is trying to solve. We're discussing the joint guideline from the ACP-GBI and the BSG.
Okay, for context, can you just quickly remind us who those acronyms represent?
Of course. The ACP-GBI is the Association of Coloproctology of Great Britain and Ireland, and the BSG is the British Society of Gastroenterology.
So really the top tier of clinical governance in this area?
Absolutely. And this wasn't just thrown together. It was developed by a 21-member multidisciplinary group. After reviewing, and this number is staggering, 13,535 publications.
13,000? Wow, that is not a light lift.
No. And their mission was singular. Create a clear, evidence-based strategy using fecal immunochemical testing, or FAT, to manage that patient flow, essentially giving doctors a hard number to go on.
And the main finding really is that FIT is a revolutionary triage tool. It offers a vastly superior positive predictive value for CRC compared to just, well, relying on symptoms. Okay, let's unpack this.
The core benefit of FIT is that it can immediately stratify risk right there in primary care. It separates patients into two very distinct pools.
Okay, what are they?
You've got the true high-risk pool who need that fast-track, urgent suspected cancer referral, and then you have a genuinely low-risk group who can be safely managed in primary care.
And here's where it gets really interesting, because to do that, the guideline had to draw a precise line in the sand. So there's one key number they recommend for that urgent referral. What is that number?
The consensus? Backed by all that data, it's settled on FHB greater than or equal to 10 micrograms of hemoglobin per gram of feces.
So 10. If the test comes back at 10 or higher, they're on the urgent pathway.
That's it.
10. It's such a precise line. I imagine a huge part of the research was making sure that 9 was fundamentally different from 10. What's the justification for setting the low-risk bar right there?
It all comes down to a comparison of absolute risk. And this is maybe the most powerful part of the entire guideline.
Go ahead.
If a patient's FHB level is below 10, their absolute risk of having CRC is incredibly low. We're talking between about 0.1 and 0.3%.
That is an incredibly low risk.
It is. But here's the crucial point. That extremely low risk of cancer is statistically comparable to the risk of severe complications from an unnecessary colonoscopy.
Wait, hang on. So you're saying for that low-risk group, the danger from the diagnostic procedure itself is about the same as the risk of us missing a cancer.
Precisely.
That makes the FIT test not just an economic choice, but a patient safety choice.
Exactly. It allows us to manage that group safely in primary care. It justifies withholding a high-risk, resource-intensive procedure like a colonoscopy, provided, of course, that proper safety netting is in place.
That sounds incredibly robust, but, clinical practice always has exceptions. When should a clinician absolutely bypass this FIT pathway?
There are two critical exceptions. First, patients who already have clinical signs of an abdominal mass that need to be referred urgently, full stop. You'd still request a FIT test simultaneously, but you don't wait for it.
Okay, and the second?
The second is crucial. Anyone presenting with an anal or rectal mass or any visible anal ulceration, they must be referred urgently without a FAT test at all. The physical finding overrides everything.
Right. Okay, that covers the clinical pathway. Let's pivot now to the statistical reality of this choice. Because anytime you set a threshold, you're making a trade-off, right? Between sensitivity catching the cancer and specificity, which is avoiding those unnecessary procedures.
That's the crux of it. And at that chosen threshold of 10 micrograms per gram, the performance is excellent. The pooled sensitivity for CRC is somewhere between about 87 and 91%.
And the specificity?
Specificity is around 84.4%. So we're catching most cancers while still filtering out a really substantial number of low-risk people.
Okay, let's translate those percentages into what they mean for a health system. Let's use two key metrics, NNS, the number needed to scope.
To detect one cancer.
Right. and NMC, the number of missed cancers per 1,000 patients. And let's just assume a 1% CRC prevalence to keep the math simple.
This comparison really highlights the dilemma. At the chasing threshold of 10, you need to perform 10 colonoscopies to find one cancer, so NNS is 10.
And what about the missed cancers?
You miss only one cancer per 1,000 patients tested. NMC is 1.
Okay, now let's imagine a health service under extreme strain. They say, we have to save resources. We're raising the bar to, say, 150 micrograms per gram. What happens then?
Well, the efficiency gains look great on paper. The NNS drops from 10 down to just 4. You only need to scope 4 patients to find a cancer.
That sounds amazing from a resource perspective, but I'm guessing there's a serious cost.
A very severe cost. The number of missed cancers. It jumps to 5 per 1,000 patients.
5 times as many misdiagnoses.
Exactly. So choosing that 10 microgram threshold means the system is accepting 4 times the diagnostic effort, just to catch those extra 4 cancers per 1,000. It's a clear choice for patient safety over resource efficiency.
And that brings us back to the role of the primary care doctor, doesn't it? Because even with this objective data, their judgment is still key for patients who fall below that threshold.
Without question, if a patient is below 10, but their symptoms are persistent and unexplained, safety netting is absolutely mandatory. A negative test can't be a reason to just dismiss them. The GP's gut feeling is still an essential safety feature.
And does the guideline suggest changing this threshold for different people, like based on age or gender?
Not at the moment, no. The evidence just isn't there yet to recommend different FHB thresholds based on things like age, sex, or ethnicity. For now, it's the same number for everyone.
That trade-off is fascinating. Okay, let's pivot from the policy to practice. How does this tool change things for patient groups that have always been tricky to manage? Let's start with iron deficiency anemia, or IDA.
Right, ID is a real puzzle. The anemia itself can mask symptoms, so historically, they often went straight to referral. The new guidance suggests using FIT to decide on the urgency of that referral.
And how well does it work in those patients?
It's incredibly sensitive. Studies show a sensitivity for CRC in IDA patients of around 96.7% at that 10 microgram threshold.
So even with anemia, it's a very reliable rule-out test for cancer.
It is. It helps separate the IDA patients who really do need that urgent fast track from those who can be investigated less invasively for other causes.
Okay, what about the second group? Patients with overt rectal bleeding. They were often excluded from older protocols. Why?
The fear was a high false positive rate. Blood from something benign like hemorrhoids could skew the results.
But the new evidence says what?
The new evidence is clear. FIT is highly sensitive, even in these patients. We're talking 96.6% sensitivity at the 10 microgram level.
So effectively the same performance. So what's the new pathway for someone with persistent bleeding but a low FIT result?
And this is a really elegant solution. If their FHB is safely below 10, they can be investigated initially with a flexible sigmoidoscopy.
A less invasive procedure.
Much less invasive. And it can often find the problem without needing a full colonoscopy, which is a much bigger deal for the patient and the system.
That's smart, optimizing the investigation. Okay, finally, what about younger patients, those under 50? CRC is rarer, but a misdiagnosis is just devastating.
It is. And FIT can be used to stratify them too. Even though the prevalence of CRC is low, maybe 1.5% in some studies, a positive FIT is still a very valuable flag.
So even if it's not cancer, a positive FIT is a strong signal that something serious is going on.
Exactly. It's particularly useful for flagging other conditions that need urgent attention, like inflammatory bowel disease or advanced adenomas, those precancerous lesions. It stops symptoms being dismissed just because of age.
Okay, let's shift focus to what happens after that positive result. Colonoscopy is the gold standard follow-up. Does the guideline support any alternatives?
It does. Colonoscopy is still the standard, yes, but the guidelines give equal weight to CT colonography, or CTC. It's considered equivalent for detecting CRC.
So the choice just depends on local resources and expertise.
Pretty much, yeah. But CTC does offer a unique advantage that was highlighted by the Sigger study.
And what's that?
Well, because it's a comprehensive abdominal scan, it also picks up extracolonic findings.
Findings outside the colon itself, such as
non-colonic cancers. In some audits, about 4.3% of patients had another type of cancer detected, or other serious conditions like a large aortic aneurysm. You're getting this extra life-saving health intelligence almost as a side benefit.
That's a huge additional value. Now, on the practical side of this, patient acceptability. This whole system relies on people actually doing the test. What does the data say about that?
The evidence is really encouraging. Over 90% of patients found the kit straightforward to use. And crucially, a big majority, over 78%, actually preferred doing a FIT test to having a full colonoscopy.
As long as the accuracy was comparable?
As long as the accuracy was comparable, yes. And this preference shows up in the return rates, which are high, somewhere between 70 and 94% in most studies.
That compliance is vital. But rolling out any system-wide test has friction points. Where do the authors think the biggest challenges are?
They really emphasize one main area: ensuring equity. There needs to be a focused effort, especially with patient education, to prevent discrimination. Some studies have shown lower acceptability in non-white ethnic groups and in areas of high deprivation.
So the system has to be proactive to make sure the tool benefits everyone equally.
Absolutely.
This has been a really comprehensive deep dive. I think the key takeaway for you, our listener, is that FIT is a robust, highly sensitive tool that provides objective risk stratification. It allows clinicians to make smarter referral decisions and frees up those valuable diagnostic resources for the highest risk patients.
And if you connect it all back, the guidelines give us this incredibly objective, data-driven pathway. We have high confidence in that data. But the system's effectiveness, it still relies entirely on two very human elements.
Which are?
Patients actually returning the sample and clinicians using their judgment and that safety netting for those with persistent symptoms. So despite all the confidence in the data, the human elements of compliance and clinical acumen, they are still the final arbiters of a successful diagnosis.
That raises a final important question for you to consider. The guideline noted there isn't enough evidence right now to combine FIT with other factors into a more complex risk score. So the question is, when will that objective data, the hard number, and clinical intuition finally combine to give us the perfect predictive algorithm? And what might we lose in clinical judgment if we ever get there? Something to mull over as this field continues to evolve.